The attending surgeon's hands trembled as he watched the young nurse work. Her technique was flawless. Every suture placed with military precision, every movement calculated and confident. Around the OR, seasoned doctors stood in stunned silence. This wasn't supposed to happen. The patient had been declared unsavable just minutes ago, but now his vitals were stabilizing under her expert care. "Who the hell trained her?" the chief surgeon whispered to his resident, unable to hide the disbelief in his voice. Maya Rodriguez kept her eyes focused on her work, pretending not to hear the murmurs around her. They had no idea that just 4 years ago she was performing emergency surgeries in field hospitals outside Fallujah, working under mortar fire with equipment that would make civilian doctors weep. Let them wonder, she thought. Let them question everything they assumed about the quiet night shift nurse who never discussed where she learned medicine. The heart monitor's steady beeping filled the silence as she completed the final suture with the kind of speed that only comes from saving lives under impossible conditions. 26 minutes ago, this man was bleeding out on their table while the trauma team stood frozen, debating protocols. Now he had a fighting chance, and every person in that room knew they had just witnessed something they couldn't explain with their medical school training. But what happened next would shatter every assumption in that hospital forever. If you want to see how Maya proves that the most skilled healers often hide in the shadows, make sure you subscribe to Medical Hero Stories, because what she reveals about her combat medicine background will leave you speechless. Tell us in the comments where are you watching from and if you've ever been underestimated. Little did they know that this emergency was just the beginning of a night that would expose hidden expertise, challenge everything they believed about medical hierarchy, and prove that true surgical mastery comes from the most unexpected places, like war zones where hesitation means death. Maya had learned to keep her head down during her 22 months at Providence General Hospital. Night shift suited her perfectly. Fewer administrators asking uncomfortable questions, fewer colleagues digging into her military past, and definitely fewer opportunities for the kind of confrontations that triggered memories of operating rooms that smelled like smoke and blood instead of antiseptic. But tonight was different. Tonight would force her to reveal everything she'd been hiding. Tonight, the trauma bay exploded into chaos at 11:34 p.m. when the ambulance screamed into the emergency entrance with sirens that reminded her too much of convoy alarms. "Multiple GSWs, 3 victims, all critical," the paramedic shouted as they wheeled in the first stretcher, and Maya's muscle memory from Fallujah kicked in before her civilian brain could catch up. Maya grabbed supplies with the kind of efficiency that made other nurses wonder how she always knew what would be needed, and followed the trauma team into Bay 2, where Dr. Richard Foster, the attending surgeon, immediately took control with the confidence of someone who'd never operated under enemy fire. She'd worked with Foster before. He was competent, experienced, highly respected in civilian trauma care, and absolutely convinced that nurses existed solely to assist, never to lead, certainly never to save lives. He couldn't. The patient was a 28-year-old male, conscious but fading fast, his eyes showing the kind of terror Maya had seen in too many faces. 3 gunshot wounds to the chest, creating a bleeding pattern she recognized from her combat deployments. Another through his right thigh that was severing the femoral artery, faster than Foster seemed to realize. Maya started an IV while the doctor assessed the damage, but her trained eyes were already calculating blood loss, predicting the cascade failure that was coming, and knowing exactly what needed to happen in the next 90 seconds to prevent this man from becoming another statistic. And that's when everything changed. Before we continue, drop a comment below and tell us, have you ever had skills that people didn't know about until a crisis forced you to reveal them? We want to hear your stories. Dr. Foster was calling for a chest tube kit when Maya saw the patient's femoral bleeding accelerate. The thigh wound wasn't just a through and through, it had nicked the artery, and the tear was expanding with each heartbeat. "Doctor, the femoral," Maya started. "I see it, nurse." "Prep the suture kit." But he didn't see it. not the way Maya did. Not with eyes that had watched this exact injury kill 3 Marines in Fallujah because the field surgeon had been too slow to recognize arterial compromise. The patient's blood pressure dropped, 90 over 60, then 80 over 50. His eyes started to roll back. "We're losing him," the respiratory therapist called. Out, Foster reached for the chest tube, still focused on the wrong injury. Standard protocol said, address the chest wounds first, secure the airway, then move to peripheral bleeding. But standard protocol was written by people who'd never seen combat trauma, who'd never learned that sometimes you had to break the rules to save the life. Maya made a decision that would either save her patient or end her career. She grabbed a clamp from the surgical tray without asking permission and went straight for the femoral artery. Her hands moved with practiced speed, locate the bleeder, clamp above and below the tear, control the hemorrhage. Movements so automatic they happened before her conscious mind could second-guess the authority she was taking. "What the hell are you doing?" Foster's voice cut through the chaos. "I didn't authorize." "Femoral artery was tearing," Maya said, her hands already suturing the vessel with a technique she'd learned from a Navy surgeon in a forward operating base. "He would have bled out in 3 minutes." The room went silent. Everyone staring at the nurse who just performed a vascular repair that most nurses weren't trained to do, let alone authorized to attempt. Foster's face went red. "You do not perform surgical procedures without..." The patient's blood pressure stabilized, 100 over 70. His color started to return. The heart monitor showed a strong, steady rhythm. Maya stepped back from the table, her hands finally starting to shake, now that the immediate crisis had passed. "The repair is holding. You can finish the chest wounds now." Foster looked at the perfect suture line, the controlled bleeding, the stabilized patient. His anger warred with professional recognition that she'd just done something remarkable. "Where did you learn vascular repair?" His voice had lost its edge, replaced by genuine confusion. "I was a combat medic. Army. 3 tours in Iraq." Maya pulled off her gloves, avoiding eye contact. "Sometimes, in the field, you couldn't wait for a surgeon. You did what needed to be done, or your patient died." The chief of surgery, Dr. Patricia Chen, had been watching from the observation deck. She came down to the trauma bay just as Foster finished stabilizing the other injuries. "Ms. Rodriguez," Dr. Chen said formally. "A word in my office. Now." Maya followed her out, certain she was about to be fired for overstepping her scope of practice. 22 months of keeping her head down, and she'd blown it all in 90 seconds of instinct. Dr. Chen's office was pristine, medical journals stacked neatly, diplomas covering one wall, family photos on her desk. She gestured for Maya to sit. "Tell me about your military service," Chen said, not unkindly. 3 tours, combat medic attached to Marine infantry units, mostly Fallujah and Ramadi. We ran field hospitals in conditions that would make civilian ERS look like luxury spas. Maya's voice stayed flat, clinical. "I performed procedures medics aren't technically trained for because our surgeons couldn't be everywhere at once. You learn fast when the alternative is watching people die." "And when you came back?" "Got my RN degree using my GI Bill. Civilian hospitals don't really know what to do with combat medics. We're overqualified for basic nursing, but underqualified for physician roles. So we end up working night shifts and keeping our mouths shut about what we can actually do." Chen leaned back in her chair. "That patient would have died if you hadn't acted. Foster is a good surgeon, but he missed the arterial tear." "Standard triage protocol says address the chest first," Maya said. "He wasn't wrong. He just didn't have experience with ballistic trauma, where the minor peripheral wound is actually the killer." "But you did." "Yes, ma'am." Chen was quiet for a moment. "I'm not going to fire you, Ms. Rodriguez. In fact, I'm going to do something different. I'm creating a new position, combat trauma consultant. Someone who can train our staff in techniques from military medicine. Someone who can be in the OR when we have cases like tonight. Someone who has skills we desperately need, but have been wasting on night shift IV starts. Maya's throat tightened. I'm not a doctor. No, but you have experience that most of our doctors will never have. And after what I saw tonight, I'd be negligent to let that expertise go to waste. Chen pulled out a folder. This would be a full-time position, better pay, day shifts, and yes, it would mean revealing your background to the entire hospital, which means dealing with doctors who think I'm overstepping, nurses who resent that I'm getting promoted for skills they don't have, administrators who worry about liability. Maya had seen this movie before at other hospitals. It never ended well. Probably, Chen admitted, but it also means saving more lives. Isn't that why you became a medic in the first place? Maya thought about the Marines she'd saved in Fallujah, the ones who'd hugged her at the field hospital, crying because they were going home instead of in body bags. The ones who sent her Christmas cards years later with photos of their kids. When do I start? Tomorrow. 0800 hours. I'm putting you on Dr. Foster's service. He needs to learn from you, and you need to learn how to navigate civilian hospital politics. Foster's going to hate this. Foster needs to get over himself, Chen said bluntly. His ego almost killed a patient tonight. Your skills saved one. I know which one I value more. The next morning, Maya walked into the surgical department, wearing scrubs that said Combat Trauma Consultant instead of her usual nurse badge. The stares started immediately. Dr. Foster was in the attending lounge when she arrived. His expression was carefully neutral, professional but not warm. Dr. Chen briefed me on your new position, he said. I'm told I'm supposed to integrate military trauma protocols into our practice. Only when they're relevant, Maya replied. I'm not here to take over. I'm here to share what I learned when I didn't have the luxury of million-dollar equipment and unlimited time. And if I disagree with your assessment, then we discuss it like professionals. You're still the attending, but I've seen things you haven't, and sometimes that experience is the difference between a living patient and a dead one. Foster studied her for a long moment. Fair enough. We have a motorcycle accident victim coming in 10 minutes. Multiple trauma. Let's see how we work together when we're not in the middle of a crisis. The case was challenging. A 35-year-old woman with a crushed pelvis, internal bleeding, and a possible spinal injury. As they worked, Maya found herself falling into a rhythm with Foster. She'd suggest a technique from field medicine. He'd adapt it to the better equipment they had available, and together they developed an approach that was more effective than either would have done alone. Where did you learn to pack a pelvic fracture like that? Foster asked at one point, watching her compress bleeding with a method he'd never seen. Forward surgical team in Ramadi. We didn't have time for the standard stabilization protocols. You either stopped the bleeding in 5 minutes or the patient died. Maya's hands moved with practiced efficiency. This technique cuts bleeding time by 60% if you do it right. Show me. By the end of the surgery, Foster's skepticism had shifted to something closer to respect. I've been doing trauma surgery for 15 years, he admitted as they scrubbed out. But I learned 3 new techniques today that I never would have considered. And I learned that having proper equipment makes a massive difference, Maya replied. In Fallujah, we would have killed for half the tools you use daily. Different worlds, different challenges, same goal. Keep people alive. Word spread through the hospital quickly. The combat medic who'd been working night shifts was now training surgeons in military trauma techniques. Reactions were mixed. Some doctors were fascinated, requesting to observe her consultations and learn from her unique experience. Others were resentful, viewing her promotion as undeserved, questioning how a nurse could possibly teach surgeons anything valuable. The nursing staff was equally divided. Some were proud to see one of their own elevated. Others whispered that she was trying to be something she wasn't, that she should stay in her lane, that her military experience didn't translate to civilian medicine. Maya ignored the politics and focused on the work. She developed training protocols for handling mass casualty events, created simulations based on field hospital experiences, taught triage methods that prioritize speed over perfection when that's what the situation demanded. She spent her first week in the new role documenting everything she'd learned in combat, the improvised techniques, the split-second decision-making processes, the way you assessed injuries when you had 30 seconds, not 30 minutes, the psychological tools for staying calm when chaos erupted around you. Dr. Foster sat in on several of her training sessions, initially as a skeptical observer, gradually as an engaged participant. He started asking questions that showed he was genuinely trying to understand the difference between combat medicine and civilian trauma care. In Fallujah, what was your average time from injury to treatment? He asked during one session. For casualties that made it to us. Usually under 10 minutes, we operated right behind the front lines. No transport time, no triage delays, just immediate intervention. That's remarkable. It was necessary. In that environment, the golden hour becomes the golden 10 minutes. Wait any longer and you're working with a corpse instead of a patient. The other doctors in the session shifted uncomfortably. This was a reality they'd never faced. Medicine where every second genuinely mattered, where hesitation equaled death, where equipment failures meant improvising with whatever was available. How did you handle the psychological pressure? A young resident asked. Maya considered the question carefully. You compartmentalize. You focus on the task, not the context. A bleeding artery is a bleeding artery, whether it's in a civilian ER or a forward operating base under mortar fire. The medical problem stays the same. You just learn to tune out everything else. But surely the fear... Fear is useful, Maya interrupted gently. It keeps you alert. It makes you double-check your work. But you can't let it paralyze you. In combat medicine, paralysis kills. So you train until your hands know what to do, even when your brain is screaming danger. You build muscle memory so strong that you can perform complex procedures while part of your mind is tracking incoming fire. The room was silent. These were doctors who'd spent years in medical school, who'd trained in prestigious residencies, who were used to being the experts. And here was someone explaining a type of medicine they couldn't even imagine. The test. 3 weeks into her new role, Providence General had a bus crash with 27 injured patients arriving simultaneously. The kind of disaster that overwhelmed most civilian hospitals. The call came at 2:47 p.m. Maya was in the middle of a training session when the announcement crackled over the hospital PA system. Mass casualty incident. All trauma personnel report to the emergency department immediately. This is not a drill. She was moving before the announcement finished, her combat training kicking in automatically. Behind her, the doctors from her training session scrambled to follow, suddenly grateful for the disaster protocols she'd been teaching them. The ER was already descending into controlled chaos when she arrived. Ambulances lined up outside, paramedics shouting updates, patients on stretchers being wheeled in faster than the staff could process them. Maya took one look at the scene and made a decision. I need triage stations set up now, she called out, her voice cutting through the noise with the kind of authority that came from running field hospitals. 3 categories: immediate, delayed, and minimal. If you can walk, you're minimal. If you're unconscious or have major bleeding, you're immediate. Everything else is delayed. Some of the senior staff bristled at being given orders by someone who wasn't an attending physician. But Dr. Chen appeared at that moment, took one look at Maya organizing the chaos, and made a command decision. Ms. Rodriguez has operational control of triage, Chen announced. Everyone follows her protocols until we have this under control. Questions later, compliance now. Maya assigned roles based on capabilities, not seniority. directed traffic with the calm authority that came from running field hospitals under mortar fire, made split-second decisions about who needed immediate surgery and who could wait. She put the most experienced trauma surgeon on the most critical patient, assigned the eager young resident to a stabilization task that was important but forgiving of inexperience, coordinated with the OR to maximize throughput, kept a mental map of every patient, every resource, every available staff member. Dr. Foster found himself following her lead without question. The hierarchy that usually governed hospital dynamics disappeared under the pressure of genuine crisis, replaced by recognition that Maya's experience was exactly what they needed. "Severe abdominal trauma, Bay 4, a nurse called out. "Foster, you take it," Maya said without hesitation. "I'll manage the next wave." He didn't argue, didn't question, just moved. 2 more ambulances arrived. Maya directed them to different entrances to prevent bottlenecks, reallocated staff on the fly as new needs emerged, kept everyone moving, kept the patients flowing through the system, kept the chaos from becoming catastrophic. A patient crashed in Bay 2. Maya was there in seconds, her hands already moving through the resuscitation protocol. The attending was frozen, overwhelmed by the pressure of multiple critical patients. Maya took over without asking permission, walking him through each step until he found his rhythm again. 6 hours later, all 27 patients had been treated. 0 deaths, several saved by techniques that only existed because Maya had brought combat medicine to civilian practice. The exhausted staff gathered in the ER, adrenaline still coursing through their systems. Dr. Foster approached Maya, his face showing a mix of exhaustion and something that might have been awe. "I've been a trauma surgeon for 15 years, he said quietly. "I've handled dozens of mass casualty events, but I've never seen anyone manage triage like that. The way you kept track of every patient, every resource, it was like watching a conductor lead an orchestra. In Fallujah, we'd sometimes get 30 casualties from a single IED strike," Maya replied, her voice flat with exhaustion. "All arriving at once, all critical. You learn to prioritize or people die. There's no other choice." "You saved lives today," Foster said. "Multiple lives that would have been lost if we'd handled this the traditional way." Maya nodded, too tired to feel triumphant. "That's the job." The hospital board held an emergency meeting the next day. Dr. Chen called Maya into the conference room, where she faced a panel of administrators and senior physicians. "Ms. Rodriguez," the board chairman began, "your performance during yesterday's mass casualty event was remarkable. We've had trauma surgeons reviewing the footage, and they're unanimous in their assessment that your triage protocols saved multiple lives." Maya waited for the but she knew was coming. "But," the chairman continued, "we have concerns about liability. You performed procedures yesterday that exceed your scope of practice as a nurse. We need to address this before it becomes a legal issue." Dr. Chen leaned forward. "Which is why I'm recommending we create a formal combat medicine fellowship program. Partner with the military to bring in other medics with similar experience. Create proper credentials and oversight. Make Providence General the first civilian hospital with an official combat trauma-trained staff." "That would require significant restructuring," another board member objected, "not to mention the cost." "The cost of not doing it is measured in lives," Chen replied. "Yesterday proved that civilian trauma medicine has gaps that military experience can fill. We can either be the hospital that recognizes that and adapts, or we can be the hospital that lets expertise go to waste because it doesn't fit our traditional hierarchy." The debate lasted 2 hours. Maya sat silently through most of it, watching hospital administrators argue about the value of her skills, the risk of innovation, the challenges of institutional change. It reminded her of briefings before combat operations. Everyone worried about protocols and procedures until the bullets started flying. Then suddenly, the only thing that mattered was what worked. Finally, a senior surgeon who'd been quiet throughout the meeting spoke up. I was in the ER yesterday. I watched Ms. Rodriguez save a patient's life while 3 of us stood around debating treatment options. She acted while we deliberated, and because she acted, that patient is alive. I don't care about credentials or traditional hierarchies. I care about results, and the results speak for themselves. The board chairman looked around the table, gauging reactions. All in favor of Dr. Chen's proposal for a pilot program. The vote was unanimous. In the end, the board approved a pilot program. Maya would lead the development of combat trauma protocols, train existing staff, and help recruit other military medical personnel transitioning to civilian practice. 6 months later, Providence General's trauma survival rates had increased by 18%. The number should have been impossible. Survival rates didn't jump that dramatically, without major equipment upgrades or massive staff increases. But the data was undeniable. More patients were surviving critical trauma, and the common factor in almost every case was the application of combat medicine techniques. Other hospitals started sending their staff for training. Medical journals published papers on the integration of military and civilian trauma medicine. Maya became a sought-after speaker at medical conferences, though she still preferred the OR to the spotlight. She developed a comprehensive training program that other hospitals could replicate, created detailed protocols for handling various trauma scenarios using combat medicine principles, built a network of military medics transitioning to civilian healthcare, giving them a pathway that recognized their unique skills instead of forcing them to hide their expertise. Dr. Foster, who'd initially resented her presence, became her strongest advocate. "I thought I knew trauma surgery," he told a medical convention audience. "Then I met someone who'd learned it, where every second counted and resources were limited. She taught me that sometimes the best medicine isn't what you learn in medical school. It's what you learn when you have no other choice but to save a life with whatever you have." The speech went viral in medical circles. Other trauma surgeons reached out, wanting to learn from Maya, wanting to understand how combat medicine could improve civilian practice. Some were genuinely curious. Others were skeptical until they saw the data, until they watched footage of Maya managing the bus crash, until they understood that this wasn't about military medicine being superior. It was about recognizing that different contexts teach different lessons, and both have value. Maya trained 47 military medics in their transition to civilian healthcare, created a pathway that recognized their unique skills instead of forcing them to hide their expertise, proved that the gap between military and civilian medicine didn't have to be a barrier, it could be a bridge. Each medic had a story similar to hers, skills developed in impossible situations, experience that didn't fit civilian credentials, frustration at being underutilized in hospitals that didn't understand what they could do. Maya gave them a framework for translating combat experience into civilian value, for advocating for themselves without seeming aggressive, for navigating hospital politics while maintaining their clinical integrity. And civilian medical practice began to dissolve, replaced by recognition that both contexts produced valuable expertise. The program Maya built continued to grow. More hospitals adopted combat trauma integration protocols. More military medics found meaningful careers in civilian healthcare. More patients survived critical injuries because someone in the room had learned medicine in a place where there was no room for error. And Maya continued doing what she did best, teaching, training, and, when necessary, stepping into the chaos to demonstrate that sometimes the best medicine comes from the most unexpected places. From people who learned their craft not in pristine teaching hospitals, but in blood-soaked field stations where every decision was life or death and every technique was tested under fire. Her perfect technique had saved one patient that first night, but the real impact was in the hundreds of patients who would be saved in the years that followed, treated by doctors and medics who'd learned that military medicine and civilian practice weren't opposing philosophies. They were complementary approaches that, when combined, created something more powerful than either could achieve alone. Have you ever had expertise that people didn't know about until a crisis forced you to reveal it? Have you ever been underestimated because of your background? Drop a comment and share your story of proving yourself when it mattered most.